thought we would do is just, we're going to have a conversation up here, and it's, I guess from both of your presentations, you touched on this a little bit, but are there, yeah, we'll get to the cards toward the end. So first we're going to have about 30 minutes of conversation here, and then we'll get to the cards and questions that folks might have about the presentations and our conversation here. So sorry about that. So I thought maybe we just start with a general question about, from your perspective as a researcher in the health system and as someone working directly with patients, kind of what are some of the specific issues or developments around hydraulic fracturing in public health that folks need to be aware of moving forward? Are there specific things that are kind of happening in your communities?
So we're looking at this from a couple different perspectives. We're looking at it from, how we have a response to the industrial activities, and then what is it that we see as the primary areas of concern. You could characterize that as, if you wanted to come up with 3 areas of concern, you could say air, water, and stress. I think those are 3 very specific areas which we are looking at. We've already done some tremendous work in terms of the well water testing. Well water testing guidelines, and that's where I wanted to refer back to something that happened in the earlier presentation with Dr. Oswald, was talking about the maximum contaminant levels, and that's, again, I would encourage people to check out our well water testing guidelines, because we've been doing some very cutting edge work there on how people can, on a very tangible, immediate way, do their own monitoring on a daily basis, on a regular basis. So that's one of the big things that my project is focused in on. Again, we really started with water because in a lot of ways water is a lot simpler than air. Air, we find, is very challenging. It's hard to know the different exposure pathways and how the different toxic chemicals may or may not be entering people's systems. But from a health perspective, I would say air, water, and stress.
And I think this would be similar. Air, water, and community impact, because those all have potential downstream effects on the individual's health. And I think, from my view, the primary difference between what we're doing and what you're doing in southwestern Pennsylvania is more a matter of scale. And we have some resources that allow us to look at a population level. You're looking at a picture at a time. And I think there's value in both of those approaches. We've actually put air at the top of our list for water because some of the short latency health outcomes are actually easier to measure. So exacerbation of pre-existing asthma would be one of them. So, but water and community is on the list as well.
And you both talked about this a little bit, but maybe this is more for you, Dr. Carey. How you see some of the work that you're doing with Geisinger's database, how that work might be used over the long term, and I guess that also applies to you to some extent. Yeah.
Well, I think really as a scientist, and I think the best data we have right now are case studies, as you heard, but those have limitations. I think what we'd like to do is move to the next level of scientific evidence, which is to do quantitative studies, and because of the regional population that we have and the broad scope, we think we can actually design some compelling case control type studies where it's easier to generate quantitative evidence. Because frankly, many people don't believe the case study reports, and I think to make this a compelling story, we need to move to the next level of scientific inquiry, and that's what we're trying to do. And I think that our ultimate goal is to ensure that the people that we care for as a health system are as healthy as they can be. And I think part of that is knowing what things that could harm their health, and where it's possible, do things to either prevent it or mitigate it or treat it. And I think that's, ultimately this data will be compelling enough that it will lead to the creation of new evidence-based policies rather than a lot of what we have now.
Along those lines, we will, for our project, again, we're not research-oriented, but I believe that our data will ultimately be worked out into case studies at the very least. We have always intended to share our data with research down the line as it's appropriate. So we've collected our data with that in mind as much as we possibly can. And again, that's not our priority first and foremost, but we really do want to assist with research and make information available in the form of case studies down the line.
I guess one of the questions that came out of the earlier presentation was just about health forms. Is proximity to natural gas drilling or natural gas drilling typically a question that's asked as folks meet with your doctor on a week, or are you seeing any change in practices as you're starting to do this work?
I would say it's not information we're collecting systematically. That may be something that we could incorporate. And through our electronic health record system, we have fairly easy ways to create data templates for physicians and primary care physicians to collect structured data. We're taking a slightly different approach, and it's I think it's the difference between the individual patient and the population level look is we're using GIS technology to map where the patients live, so they don't have to tell us if they live near a gas well. We know if they live near a gas well, and that's the level of the first look at the data that we have is at the population level. But then, as I said, that's kind of a hypothesis generator to give us an idea of where the major concerns might be, find them, so then we can then do a more detailed study that probably would look at individual patient level.
And that question for us raises a whole host of other questions and a fair amount of conjecture at this point, because what we are hearing, certainly on the ground, from people who have come into our office, and it's a relatively small sample size at this point, is almost that there's a wall of silence in some ways, and that silence comes from so many different directions. First of all, the healthcare providers may not really know how to tackle this issue, so they treat the symptoms. They see this as an issue more of these symptoms. So people are getting their nosebleeds treated, they're getting their asthma or their respiratory problems treated, but there's not any sort of systematic sense of, well, this is or is not related to gas drilling activities, and that's not necessarily accidental. You have to bring to play then the legal ramifications of this, non-disclosure agreements. People are under gag orders, so they may or may not feel free to actually say this to their healthcare providers. And their healthcare providers, because of Act 13 and other things like that, may or may not feel free to even ask these questions. And even if they ask the questions, they don't have the amount of data and information for them to be able to respond to patient concerns. It's because there's so much data lacking, and you've got the legal ramifications. On top of that, it's a problem.
So I'm obviously not a health professional, but every once in a while when I read an article about health impacts, I'll see somebody saying there needs to be a large epidemiological study, and I may not even be using that phrase correctly, but and I just was wondering if you could talk about your thoughts on that, and kind of some of the benefits or not benefits of the need to do that kind of study.
I think it's sorely needed, and it's incorporated into our study design. So we have epidemiologists who are part of our study team, and I think the benefit that brings is a certain amount of scientific rigor in terms of study design, data analysis, that frankly, when it's presented to other scientists and policy experts, is the level of analysis that they want to see and are comfortable with. So I think I would agree with the statement that an epidemiological study is certainly warranted and needs to be done.
Yes, we very much intentionally decided that was not going to be our scope, and so I can only comment to the extent that we've chosen to not go down that path, because we didn't want to get distracted by taking action, or from taking action. So I think that those type of activities, we support them, we want to see them happen, but we don't want to see them delay action in the meantime. So if that were to take resources away from providing a tangible response to the community, that would be a concern. But at the same time, you know, ultimately, I mean, is real political action going to take place without that? I can't answer that question.
Can I just elaborate one more point? So this is a problem that's not readily amenable to a traditional academic environmental health epidemiologist study. And so the academic environmental health epidemiologists, they like to know what the exposure is that they're looking for. They insist on measuring that exposure in individuals and then linking it in a very rigorous and quantitative way to the outcome. Because of the complexity of what we're dealing with, I don't think that that's really feasible at this stage. And I've actually had some discussions with some very well-known and very accomplished environmental health epidemiologists who argue that absent that level of scientific rigor, you're not going to learn anything useful. We don't agree with that. And that's where we think that the approach we're taking, which is in many ways a very novel and innovative approach, using electronic health record data to basically do a population epidemiology type study, we think is a great way to get started. And we agree that time is of the essence, and the sooner we get this rolling, the better off we'll all be.
Now we've heard a little bit today about doing, well, I guess one of my questions is if you could both share a little bit about the cost of doing this type of work. We heard a little bit during your presentation, Raina, about that there's not state funding to do some of the work that maybe the Marcellus Shale Advisory Commission had suggested, and on the federal level, I've also heard there's maybe not as much funding, you might hope, coming out of the CDC or other public agencies. So I just was wondering if you could talk a little bit about the cost of the work that you're doing and some of the funding concerns or issues that you're running into.
Well, I don't know if it impressed you, but what we're proposing to do, I think, is fairly ambitious and has a lot of aspects. So we've had a lot of discussions with government funding agencies, as well as private foundations and individuals. And I would say so far we've had the most traction with private foundations. And the funding we have to date is actually funding that came from a local foundation. It's funding we've done so far, and will fund the initial pilot projects. One of the advantages of the approach that we're proposing is that, honestly, the health data, most of the health data that we're going to use for the study is collected as part of medical care in our region. So someone else is paying for that. We're leveraging that and using it for reasonable purposes. It is an extremely powerful and I think effective approach. The most expensive part of what we getting the data that we need to do the study is really the environmental assessment. We've talked to a very well-known environmental scientist who's part of our study team, and he's got a plan for doing large-scale water sampling, and his estimate is that to measure and analyze all of the components in water that he'd like to see, it would cost $1,000 per sample. So you add that, multiply that by 500 or 1,000 wells, if you want to do it before and after drilling, and maybe 5 years later, look at it as a function of well age, those kinds of things. You're talking about millions of dollars for this type of study.
So for our project, we're relatively bare bones, and it's probably very important for us in particular to actually get primarily our funding from private foundations, which we do at this point. It's definitely imperative that we wouldn't take certain funding. But the Heinz Endowments, the Clean Foundation has been an early supporter and a consistent supporter, so a huge shout out to both of them. And we've also gotten some support from the Pittsburgh Foundation in our area. So we've gotten a good amount of support from the funding community, and we've gotten a tremendous amount of support both from those foundations as well as from other people who've given us incredible amounts of in-kind support and expertise. So in that sense, we're somewhat well off, but we're trying to do a huge project, cutting it out, sorry, a huge project on a shoestring budget for the most part. I mean, if we are stepping in to do what the state of Pennsylvania ought to be doing with the state Department of Health, probably couldn't have sufficient resources to do that. But I mean, because again, we can move so fast because we're not slowed down by really any of the political problems that might be out there. We can do a lot with a relatively small amount of money. So that's our focus. And again, we're trying to translate this also to the residents in southwestern Pennsylvania who are also trying to do a tremendous amount with almost next to nothing. And so, you know, coming up with low-cost devices, coming up with ways that they can monitor for, you know, with a $10, $15 piece of equipment, just to give themselves a sense of, okay, now we saw a spike, so that warrants further testing. But we're not going to, have that testing done without that at least basic information to alert me to that problem. And again, from the public health perspective, even with that minimal amount of equipment, you can start to make decisions to have better impacts for your health, such as, wow, something terrible has happened to my water. I don't know what it is, but I can stop drinking my water. And I do have a certain amount of information that confirms that.
So I have a couple of other points I want to make. So Geisinger, we're a non-profit private healthcare system, but a lot of what we've done up to this point, we've self-funded, so a lot of it's paid on our own time. The other point I want to make, and I'm going to go back to a comment that Dr. Oswald made about industry funding. And this is kind of, it's maybe dangerous. Get a response from the group here as to how that would color your impressions of what we were doing. Because I've had scientific colleagues who have told me that if you take a dime of money from industry for this, I won't believe a word you say. On the other hand, I think Dr. Oswald's made a very compelling case for the fact that I think industry maybe should pay for some of this. And I think the analogy to the pharmaceutical industry is pretty apt. So
they should steal it from us, so we don't do it. Tax money.
We can't do that. So if any of you have, comments or thoughts you'd like to share on that, I'd like to hear it. And maybe we can wait till the, I don't want to override our moderator, until the open question and answer.
Yeah, that would be great. And so something that you brought up, Raina, was that, obviously folks in southeastern Pennsylvania and a large chunk of Pennsylvania are not necessarily dealing with these issues in our backyard. And this was a challenge, I know, for the funding community to a certain extent in southeastern Pennsylvania. So I just was curious to ask you all this question about, why should folks on the eastern part of the state or the southern part of the state be concerned about this issue, and what are potential implications that might be statewide, but then also kind of might travel?
Well, that's a really good question for one reason in particular, because you're not so implicated in this region, so you have fewer irons in the fire. You can be more neutral, and a lot of the people in southwestern Pennsylvania struggle with that, I think, because almost everybody has a stake in the game there. Even if you haven't done anything with the industry, chances are somebody in your family has, chances are your neighbor has, chances are your physician may have. Almost nobody